we're going to discuss the structure of the human tooth. We humans have only two dentitions. The primary dentition, also known as the baby teeth. The first tooth erupts around the age of 6 months, followed by the permanent dentition, which starts around 6 years. The period between 6 and 14 years old is referred to as the period of mixed dentitions, where both primary and secondary dentitions are present. Among primary teeth, there are 20 of them, 10 in the upper jaw, known as the maxilla, and 10 in the lower jaw, known as the mandible, a total of 20 teeth. In primary teeth, there are two types of incisors. These are the front teeth, centrals and laterals, and two types of molars. These are the back teeth, first and second. All primary teeth are normally later replaced with their permanent counterparts. The primary teeth are significantly smaller than their permanent counterparts and are usually characterized by large interproximal spaces visible in this image. Among the permanent teeth, 16 are found in the maxilla, the upper jaw, and 16 in the mandible, so there is a total of 32 teeth. In each of these, there are typically 4 incisors, which are the front teeth that we showed during our smile, 2 canines, also referred to as the eye teeth, 4 premolars, sometimes referred to as bicuspids, and 6 molar teeth. Many people have heard the term wisdom teeth and assume that there is something inherently wrong with them, as they often seem to be slated for extraction. Turns out that these teeth are no different in structure than their counterparts. What is different is that those teeth are the very last teeth to erupt into the jaw, somewhere between 17 and 21 years of age. Often, there is not enough space for these teeth to erupt properly. So what happens is that in these situations, partial eruption may occur, leading to gum infection, abscess, and cavity formation on the adjacent teeth. At times, there is so little room that these teeth never erupt and remain completely embedded in bone. This condition is known as a full bony impaction, and it can lead to cyst formation and other tumor formations. So there's often a dilemma whether those impacted teeth should remain embedded or should they be extracted, and that decision has to be done in conjunction with a qualified oral surgeon. The tooth itself consists of 2 major parts, the root and the crown of the tooth. The crown is that part that sticks above the gum line, and the root is that part of the tooth which is embedded in bone. The root generally is twice as long as the crown, and that ratio is necessary to maintain the stability of the root. The front teeth are generally single-rooted teeth, meaning there is 1 root per tooth. However, the back teeth have 2 or 3 roots. The maxillary or the upper molars have 3 roots per tooth. The mandibular molars have 2 roots per tooth. And of course, the extra roots provide the tooth with additional support. In multi-rooted teeth, there is an area where the roots divide, which is known as furcation. In healthy dentition, this furcation is completely embedded in the bone. However, during periodontal disease, when there is bone loss, the furcation becomes exposed to saliva and bacteria and can often lead to formation of abscess and other infection. When this happens, this condition is known as furcation involvement. Shown in the pink, there is the pulp chamber, which is underneath the hard structure of the tooth, and it contains the tooth nerves and the vascular supply. Pulp chamber is, the dental pulp is the central part of the tooth filled with soft connective tissue. This tissue contains blood vessels and nerves that enter the tooth from a hole at the apex of the root. Let us look at the cross-section of the tooth, and we will see that there is enamel, dentin, cementum, and the dental pulp. and we will discuss each section separately. Let's start with the enamel. Enamel is the hardest and the most highly mineralized substance of the body. 96% of the enamel consists of mineral, with water and organic material comprising the rest. The normal color of enamel varies from light yellow to grayish-white. Some enamel is semi-translucent. The color of dentin and any restorative dental material underneath the enamel strongly affects the appearance of the tooth. Enamel can vary in thickness over the surface of the tooth and is often thickest at the cusp, up to 2.5 millimeters, and thinnest at its border, which is seen clinically at the cemento-enamel junction. Beneath the enamel is the dentin. Dentin is the substance between enamel or cementum and the pulp chamber. It is created by the odontoplast of the pulp. This porous yellow-based material is made up of 70% inorganic materials, 20% organic materials, and 10% water by weight. It is less mineralized and less brittle than enamel, and it is necessary as an underlying structure for the enamel. Because dentin is softer than enamel, it decays more rapidly and is subject to severe cavities if not properly treated. The dentin has microscopic channels called dentinal tubules, which radiate outward throughout the dentin from the pulp cavity to the exterior cementum or enamel border. The diameter of these tubules range from 2.5 millimicrons near the pulp to 1.2 millimicrons near the mid portion and 900 nanomicrons near the dento-enamel junctions. These dentinal tubules contain cell projections known as the odontoblasts, which connect with nerves axons in the dental pulp. The exposed dentin is very sensitive to thermal changes as it causes movement of fluid in the odontoplast projections, which anastomose with nerve endings. Cementum is that structure which covers the root of the tooth. It is a specialized bone-like substance. It is approximately 45% inorganic material, namely hydroxyapatite, 33% organic materials, and 22% water. Cementum is excreted by cells known as cementoblasts within the root of the tooth, and it's thickest at the root apex. The principal role of cementum is to serve as a medium through which periodontal ligament can attach and render the tooth its stability. The cellular cementum is very active at the root of the tooth, and it compensates in length for the attrition of the tooth. The area where the cementum and the enamel of the tooth meet is referred to as CEJ, or the cemento-enamel junction. The structure has very important clinical significance. So there are three possibilities of this junction. In some instances, the cementum overlaps the enamel. In other instances, enamel overlaps the cementum, but in some cases, the cementum and the enamel actually do not meet, leaving the area of exposed dentin. In these situations, the patient tends to have increased sensitivity to thermal stimuli such as hot and cold. The dental pulp is the central part of the tooth filled with soft connective tissue. This tissue contains blood vessels and nerves that enter the tooth from a hole at the apex of the root. Along the border between the dentin and the pulp are odontoblasts, which initiate the formation of the dentin. Other cells in the pulp include fibroblasts, preodontoblasts, macrophages, and T lymphocytes. This area is commonly referred to as the nerve of the tooth. Another important aspect to remember is the occlusion, or how the teeth come together. The study of occlusion involves both the static and the dynamic relationship of maxillary to mandibular teeth. So the most common classification of the static occlusion is the so-called angles classification. In angle class 1, the maxillary teeth just overlap the mandible. In class 2, the maxillary teeth, especially the front teeth, are positioned forward to the ideal place. And in class 3 malocclusion, the mandibular lower incisors overlapped the maxillary teeth, resulting in protrusion of the jaw. In dynamic occlusion, we consider how the lower and upper jaw meet each other during movements. It is important that the truing forces or the closing forces of the upper and lower jaw should be equalized so that the pressure is even on both sides. Imagine a dining room table with 6 legs, with one leg even a few millimeters longer than the other 5. If people were to lean on such a table, that particular longer leg would get more pressure and would either buckle or would become loose. Pretty much the same situation happens in human dentition. If one tooth hits the opposing tooth prematurely, the tooth then sustains increasing occlusal forces, which can result in increasing wear facets or loosening of the tooth. Other signs and symptoms of occlusal trauma may include thermal sensitivity, increased mobility, trismus, and clicking of the temporomandibular joints. When such conditions exist, the dentist needs to correct it either with occlusal adjustment or with appliances which minimize such destructive forces.